So this is a nice ongoing collaboration with the Health Tree Foundation, which I've been grateful to work with them on that, and to all the patients who filled this out. And brief, this is a survey of almost 600 patients with myeloma, which to me is mind-boggling, and I'm very grateful for their time to go online, log on to Health Tree, and fill out the survey for us. In brief, you may remember people who've seen me wearing a bright color shirt of prior iterations of this, that a year ago I presented data all from a different Health Tree analysis of real-world data. Patients had linked their EMR records or electronic medical records to HealthTree's portal, that we saw that lifetime dosing of dexamethasone was associated with a higher risk of visually significant cataracts. That patients actually noted interfered with their ability to drive or inability to enjoy their daily activities and so forth. And that's now been published in the American Journal of Hematology. The caveat, and we made very clear that, and the reviewers did as well, was that there are some confounders there. Age is a big one, right? The more time that someone's on Dex because they're just alive and they're alive with myeloma, yes, their cumulative dose of dexamethasone in milligrams and then grams will go up. And as people get older, the risk of cataracts goes up. So how do we know that that wasn't the confounder here? And so what we did was we actually looked at, again, 582 patients from several countries with myeloma who filled out the survey. We asked them about cataracts. We asked them about eye health. We asked them about glaucoma, all of those features. In brief, we found, and in the poster you'll see an actual model, that in an age-adjusted logistic regression model, independently of age, or I should say at every level of age, you saw that the higher someone's dose of Dex on average, the higher their risk of cataracts, almost like a 10% increase from high dose Dex versus low dose Dex. So that validates what we were hypothesizing before, that it truly is the dexamethasone that's putting people at risk of cataracts. We didn't see an association like that with glaucoma, probably because the N was a little bit too small. But I think this validates some of the work that we've been shouting from the rooftops for the last year or two, is that, in the era of daratumumab and bispecific antibodies, all these newer things, is this vestigial dexamethasone from decades ago truly still necessary in myeloma treatment paradigms, especially when it's so toxic to patients? I would argue no, and we're now prospectively studying, our group is looking at trying to drop the Dex after 1 or 2 cycles. Again, in the first cycle, dexamethasone is helpful because it lowers infusion reactions, helps with pain and so forth. After the first couple of cycles, I really don't think it's adding that much. And again, to be clear, in all these studies, both the last one and this one, even if someone thinks that they're not having troubles with the Dex, even if the patient says, oh no, I'm sleeping okay on the dexamethasone, I'm not jittery, my partner doesn't hate me, I'm not super angry on these days, they're still at risk. Like that patient is still at risk of toxicities from the dexamethasone, most notably cataracts, which are very important to older adults. Many of them who live independently need to be able to drive. And I think it's important to note that, that's independent of age, both younger and older patients. So we're going to use this as part of our growing burgeoning field of evidence suggesting that, again, dexamethasone is helpful up front, but after the first couple of months, I would suggest dropping it.